I understand you've noticed a lump on the left side of your neck?
Yeah, I saw it about 3 weeks ago. It's firm, but it doesn't hurt.
Alright, let me take a look at it. Tilt your head a little. I'm feeling a firm, rubbery swelling here, roughly 1.5 centimeters. No tenderness?
No pain at all.
Okay, and it's been there 3 weeks.
Though painless at rest, the patient reports that the lymph node becomes painful specifically after alcohol consumption, a rare but classic feature of Hodgkin's lymphoma.
Tilt your head a little for me. There, tender.
The discomfort localizes to a single cervical node, shown here in orange.
You noticed any so-called B symptoms? Things like night sweats, fevers, or unexplained weight loss?
Yes, I did. For example, I experienced drenching night sweats, a 10-pound weight loss over 6 months, itchiness, pruritus, and recurrent unexplained fever known as Pell-Epstein fever.
All symptoms of Hodgkin's lymphoma. But what is Hodgkin's lymphoma? It is a malignancy of the lymphatic system arising from lymphocytes and is defined by the presence of Reed-Sternberg cells.
For example, classical Hodgkin's lymphoma is characterized by a specific type of Reed-Sternberg cell, known as the owl-eye variant. This name comes from the cell's distinctive microscopic appearance, a large binucleated cell.
Let's compare two very different patterns of lymph node involvement. Clinically, Hodgkin's lymphoma spreads in an orderly, contiguous manner from one lymph node group to the next, unlike non-Hodgkin's lymphoma, which spreads unpredictably. Recognizing this difference is key to diagnosis and treatment planning.
A small pinch.
Okay.
There we go. Keep still. And all done.
Laboratory investigations reveal an elevated erythrocyte sedimentation rate and increased lactate dehydrogenase, indicating an underlying inflammatory process.
Chest X-ray demonstrates a large mediastinal mass representing bulky disease that is characteristic of Hodgkin's lymphoma in young adults. If you look right here in the center of the film, there is a broad, dense opacity occupying the entire mediastinum. It extends from the top of the chest all the way down to the heart and blends with both hela.
Diagnosis is confirmed through excisional biopsy of the enlarged cervical lymph node, which allows preservation of nodal architecture. The node is removed intact and placed in a sterile container with preservative solution for detailed histopathologic evaluation.
Hodgkin's lymphoma is staged according to the Ann Arbor staging system. Stage 1 refers to involvement of a single lymph node region, such as the cervical nodes, or involvement of a single extranodal site or organ.
Stage 2 occurs when 2 or more lymph node regions are involved on the same side of the diaphragm. It may also include localized involvement of a nearby extranodal organ, together with regional lymph nodes.
Stage 3 describes disease that has spread to lymph node regions on both sides of the diaphragm. It may also involve nearby extranodal tissues or the spleen.
Stage 4 represents advanced disease, characterized by diffuse or disseminated involvement of distant extranodal organs, such as the liver, bone marrow, or lungs.
The most common subtype of classical Hodgkin's lymphoma is nodular sclerosis, accounting for approximately 60 to 70% of cases. It mainly affects young adults and shows a slight female predominance. The mediastinal lymph nodes are most commonly involved, followed by the cervical lymph nodes.
40% of patients present with systemic B symptoms, such as fever, night sweats, and weight loss. Mediastinal involvement can sometimes produce bulky disease visible on chest imaging. Biologically, the lymph node is divided into nodules by thick bands of fibrosis. The characteristic Reed-Sternberg variant seen here is the lacuna cell, which appears to sit in a clear space due to cytoplasmic retraction during fixation. A mixed inflammatory background of
Cellularity Hodgkin's lymphoma accounts for approximately 20 to 25% of classical cases. It shows a male predominance and occurs more frequently in children, older adults, and immunocompromised patients. Around 70% of cases are associated with Epstein-Barr virus infection.
The lymph nodes are commonly involved, while mediastinal disease is less frequent. Patients frequently present with systemic B symptoms, and advanced disease may involve the spleen, liver, or bone marrow.
Histologically, the lymph node architecture is diffusely effaced. Classic Reed-Sternberg cells with the characteristic owl-eye nucleoli are commonly observed. The background contains a heterogeneous mixture of lymphocytes, plasma cells, histiocytes, and abundant eosinophils. Lymphocyte-depleted Hodgkin's lymphoma is the rarest classical subtype, accounting for less than 1% of cases. It is most commonly seen in elderly patients or individuals with advanced HIV infection and typically presents with widespread disease and systemic B symptoms. Microscopically, numerous pleomorphic and bizarre Reed-Sternberg cells are present, while normal lymphocytes are markedly reduced. Areas of necrosis, fibrosis, and apoptotic or mummified cells may also be seen. This subtype typically presents with advanced systemic disease and carries the poorest prognosis. Lymphocyte-rich classical Hodgkin lymphoma accounts for approximately 5% of classical Hodgkin lymphoma cases and shows a male predominance. It most commonly involves peripheral lymph nodes such as the cervical and axillary nodes, while mediastinal and extranodal involvement are rare. Epstein-Barr virus is detected in about 40% of cases, and this subtype generally carries the most favorable prognosis out of all classical Hodgkin's lymphoma types.
Physiologically, the background contains a dense population of small mature B lymphocytes, while classic Reed-Sternberg cells are rare. Because of this lymphocyte-rich environment, the disease generally carries an excellent prognosis. This type resembles nodular lymphocyte predominant Hodgkin's lymphoma, therefore must be distinguished. Nodular lymphocyte predominant Hodgkin's lymphoma represents a distinct non-classical variant. It typically presents as a slow-growing, localized disease involving cervical or axillary lymph nodes and generally has an excellent prognosis. Let's shift to the pathology of this subtype. On the screen you can see nodular architecture packed with small lymphocytes, and within it a distinctive large cell. The characteristic tumor cell is the lymphocytic and histiocytic cell, also known as the popcorn cell.
Like classical Hodgkin's lymphoma, these tumor cells express B-cell markers such as CD20 and CD45, while they lack the classical markers CD15 and CD30, which are normally found in classical Hodgkin's lymphoma. Therefore, this immunophenotype helps distinguish this entity from classical Hodgkin's.
Initial evaluation begins with a thorough physical examination, including palpation of cervical, supraclavicular, axillary, and inguinal lymph nodes, along with assessment of the liver and spleen.
Oh, doctor, that tickles.
Try to stay still. I'm assessing your liver.
Investigations include a full blood count, where leukocytosis, lymphopenia, or anemia may indicate poorer prognosis, along with liver and renal function tests, lactate dehydrogenase, and erythrocyte sediment.
No, don't worry. This is necessary to confirm the diagnosis. An excisional biopsy is required to preserve lymph node architecture. Histological examination reveals Reed-Sternberg cells, which are large malignant cells of B-cell lineage. Front centers locally specify.
All right, we've got the diagnosis. Now for the battle plan. This cancer is highly treatable, with about an 80% cure rate. For most, the main weapon is a chemo combination called ABVD. It's a 4-drug powerhouse. For tougher, high-risk cases, a regimen called BACOPP. After chemo, they'll often use targeted radiation. But what about that other 20%? High-dose chemo and a stem cell transplant. And it's not just chemo anymore. We have these amazing biological tools that act like smart bombs. This is precision medicine. Rituximab, for instance, targets the exact marker on our patient's cells.
Here's something that is so important but often gets overlooked: dental care. These cancer treatments are tough on the entire body, but they can be especially brutal on the mouth. It is absolutely crucial to put off any elective dental work for a while. We're talking 3 to 12 months after treatment, and everything has to be coordinated with the cancer team. For dentists, the job really shifts to managing some really nasty side effects, things like mucositis and xerostomia. Taking care of this stuff is a huge part of making sure someone's quality of life is protected, not just during treatment, but for the long haul.